ఎవరో బాయ్ వచ్చినట్టున్నారు కదా. హాట్ వాటర్ తాగు. స్నానానికి. నీళ్ళు పెట్టలో బకెట్ పెట్టి వేడి నీళ్ళు పెట్టి ఫాస్ట్.
శ్రీకాంత్ ఎందుకు వెయిట్ చేస్తున్నావు?
సార్ గుడ్ మార్నింగ్
శ్రీకాంత్
సార్.
good morning.
అదే ఒక 10 people అలా వస్తే స్టార్ట్ చేద్దాం సార్.
ప్రజెంటేషన్ కి అయితే 10 people, ఇప్పుడైతే అందరూ మాట్లాడొచ్చు కదా. స్టార్ట్ చేయలేదు కదా, టైం ఉంటాయి కదా.
ఓకే సార్. అదే అంటే బిఫోర్ వి స్టార్ట్ ప్రాక్టీస్ గైడ్లైన్స్, ఎనీహౌ సతీష్ సార్ హెస్ పాయింటెడ్ అవుట్, అంటే అది యాక్చువల్గా ఇవాళ క్లాస్ అనుకోలేదు, బట్ లైక్ వాట్ డూ యూ థింక్ అబౌట్ ఆస్పిరిన్ విత్ హోల్డింగ్ అండ్ ఆల్?
ఎందుకు విత్ హోల్డింగ్ అవసరమా?
అదే సార్ మామూలుగా
యాజ్ యూ సెడ్ ఎస్టర్డే, నీ మైక్రో సర్క్యులేషన్ కి ఆస్పిరిన్ బెటర్ ఏమో అనిపిస్తుంది నాకైతే.
వాట్ ఆర్ వి ప్రాక్టీసింగ్? అనురాధ మేడం కార్డియాక్ సర్జరీస్ లో ఏం చేస్తున్నారు?
ఏం మరి అడగాలి, అడగండి.
Anyone else who can speak and like what are we doing with aspirin especially? The 2019 లో అయితే యాక్చువల్గా they have released an update to anticoagulant uses, sir. So they have created now separate guidelines for regional anesthesia and pain procedures. So for low risk pain procedures and for surgeries, aspirin they told to continue, sir. Bashir, ఒకసారి నన్ను హోస్ట్ చేస్తావా, co-host, so that I can mute people. So the some green bloods elimination half-life basis మీద they're framing the guidelines, sir. So based on that, actually 2 half-lives తర్వాత 25% of drug remains in the body, and 5 half-lives తర్వాత only 3% of drug remains in the body. So that is the period they are actually taking into account while framing these guidelines.
So half-life duration ఎంత?
Sir, 5 half-lives, sir. 5 half-lives for any drug.
2 half-lives duration ఎంత aspirin కి?
5 half-lives 6 days ఇచ్చాడు, sir. So it will be like around 2 days maybe. So every day of abstinence 10 to 15% platelet function improve అవుతుందని ఇచ్చారు, sir. So for routine surgeries and all, and low risk and I mean like for spinal and low risk pain procedures, they're actually asking to continue aspirin, no problem with that, hematomas and all. But again, what does he mean by low risk pain procedures? Maybe some trigger point like that maybe, but epidural, again he is asking for a pain procedure, he is asking to withhold for 6 days, sir, aspirin. That is the 5 half-life period for aspirin, because when we are dealing with a pain patients, they are generally elderly, generally having some post-laminectomy pains or scarring, spinal canal stenosis, all these problems are there. So primary prophylaxis 6 days and secondary prophylaxis post-procedure 4 days withhold, he is asking us. For surgeries and all, he is asking to continue. That's with actually what Satish sir asked before the. So this is basically today's class. I want to just it's on my mind since long to discuss what are all the, because more and more legal suits are coming up, and we are going to near future almost like in western part we will also face lot of lawsuits, and also the insurance cases are rising up. So so what are the actually the practice guidelines we should know? Because first thing to say or skin the vigilance part and all the things we have to take care of. But being a member of a national society is the first point, and adhering to their guidelines. If we do practice, it's more like we can say these are the national guidelines given for following all the procedures and all. So ISA has published a detailed guidelines about minimum monitoring standards in operation room, functioning of city. This actually guidelines have 4 sections. So the section 1 is minimum mandatory standards in operating room. 2 is functioning of city branches. 3 is ethical conduct of anesthesiologist. And 4 is the never-ending problem, remuneration of the anesthesiologist, RVG system. So whoever is free like that, they can on their cameras so that we can see each other, because this is basically a discussion class. So coming to the first part, minimum mandatory standards in operating room. So the specialty of anesthesiology requires a lot of vigil on the part of anesthesiologists, we all know. So this includes the presence of anesthesiologist as well as lot of monitoring equipment. So this presence of anesthesiologist is the first point. So we may think that this is not something like around 20-25 years back we are discussing. So today everyone is there in the operating room and all. So unfortunately, even today, like many places,
Voice out.
sorry, suddenly it got disconnected. I don't know.
Voice పోయింది.
Sir, అందరిదే అయింది. Yeah, yeah. And yeah, so what I'm going to say, the presence of anesthesiologist, unfortunately, it's the sad scenario even today also. So sometimes freelancing anesthesiologists are actually not being present exactly in the operating room. So in places like uh, Kammam and all, where my friends work, there are so many places. I'm just saying for an example. So where they give the spinal stay for 15 to 20 minutes for cesarean. They will wait till baby delivery and all, and then run to another place, give spinal there or GA there. Most of them, but generally don't play with the general anesthesia cases, but regional anesthesia mostly still there are instances where. We run from place to place, not being present. And another problem is we are there in the hospital, there in the operation theater. There is my friend in Karnool who runs 4 operation theaters, keeping assistants parallelly. So this is in 2023. So this is the state of working conditions, maybe sometimes by force or sometimes we out of or need for earning more money and all, we are doing this. So what are your views on this very important topic of presence of anesthesiologists? So what the guidelines, ISA guidelines say, the operating surgeon and hospital must ensure the presence of a qualified and registered anesthesiologist in the operation room where a patient is undergoing a procedure under anesthesia. So it is first primarily the responsibility of the surgeon and the hospital to ensure a qualified anesthesiologist is there. Recently, we have even it came in papers where they have operated without anesthesiologist, a GA case or regional case, something. The patient died, and there was a lot of uproar about that case in the papers too. So it is on their part also. They must ensure adequate people, anesthesiologists are there to handle those cases. how much our share or responsibility is there in being present, or in how many cases we are being culprits? Is this practice still going on even in corporates, or only limited to the rural or semi-urban settings? What are your views on this one? Presence of anesthesiologist. Kiran Mehta ji sir, those who are working in rural can throw some light.
I think in corporates, yeah, Srikant, and Dr. Srinivas.
Sir. Good morning.
Yeah, in corporates in Hyderabad, at least, the most of the almost all hospitals, one anesthesiologist will be present in the theater. But in a teaching institutes like when there is a DNV program, what is happening is one qualified specialist, fully qualified specialist may not be on the bedside continuously. Their PG, third year PG or second year PG will be monitoring. One person will be going here and there. Maybe one consultant for two patients are there, but either a PG or a doctor is compulsory there in the consultant is compulsory there in the theater in the operating room side. Um, in every corporate hospital and in most of the private practice hospitals also in Hyderabad, the anesthesiologist is present till the end of the surgery. That I can say.
That's
Maybe remuneration wise, I don't know, but I'm not practicing. Anyway, it will be less. But this is the thing. Yeah, over to you, Srikanth.
Thank you, sir. Thank you. That was definitely good enough practice going on there, sir. So, what are your views of this presence of anesthesiologist Shekhar, Chaitanya, Kiran? Those were practicing outside also in the periphery, even though Kiran, we can say it's a role plus, but sort of corporate setup in GMR care.
As far as I am concerned, good morning, Srikant.
Yeah, morning.
Yeah, even in corporates we are understaffed. That's true. But just like Srinivas sir said, if we are monitoring by training the PGs, and we may not be there all the time in the theater by the side of the patient, but we will ensure that a PG or a trainee should be there all the time throughout the case with a particular case, and he should follow and he should inform the specialist who is qualified anesthesiologist of every single event that occurs in the theater, because we are running around 4 to 5 theaters at the same time. So that's what happening in as of now in Care Vizag too. So coming to the remuneration part, we are still not getting enough remuneration outside because it's all depends upon the hospital and the surgeon in the freelance practice also, and we are also too greedy that we don't want to lose that case by demanding more. That's what I feel.
That's the main thing, losing the case. That's the pressure from management part also in many hospitals.
Most important is that we don't want to lose the patient. That's the reason why we are getting less money.
Yes, sir. More and more hospitals out of proportion to the, at least in Vizag, we are facing that problem now. The hospitals have developed, but not the population or the IT industry. Chaitanya, any views on this one? So, presence of anesthesiologists, have you faced any problems like that? Okay, we'll quickly move ahead. So, coming to pre-anesthetic checkup and investigation, the surgeon should request the PAC of the patient from anesthesiologist before listing the patient for OR. The necessary investigations, references, and optimization of the patient should be done in consultation with the anesthesiologist. So, the ISA recommends a patient questionnaire PAC chart to be used by all anesthesiologists. So there is this, I will share this PDF with you, but there is a beautiful questionnaire and pre-anesthetic checkup chart given by ISA, but if we can implement, actually, a few days back, I have discussed with Omkar and all. It's a 4-page complete consent form and the PAC questionnaire, but that's quite good enough. But practically, how much we can spend the time and all, we have to see. So there is initially a self questionnaire sort of things like that. If you can see this one. So anyhow, I will share the PDF with you. So they mention the regular patient's name, address, registration, surgeon, anesthesiologist, and all, and briefly a few lines about the general anesthesia and regional anesthesia. A paragraph is there. So then there is a questionnaire where we will ask the patient to fill it if he is educated, or if he is not educated or doesn't understand the complicated lang stuff and all, so they can take the assistance of some attendant of them who is educated enough to give the answers. So this covers like, do you have any chronic medical condition for which you need to visit a doctor regularly? Do you take any medication and all? So more or less the same things we ask in PSC, but it's in a written form and to be filled by the patient, not by the anesthesiologist. So do you feel breathless on walking? Have you undergone any surgery in the past like that? So it's totally 11 questions are there in this one. So then followed by pre-anesthetic checkup to be performed by qualified anesthesiologist, and that's the regular stuff we do. And but it has a complete detailed considerations for anesthesia care, for important do's and don'ts after surgery, and also it wholesale covers everything like possible complications and all. So it has at the end patient affirmation, patient signature, witness signature, and doctor signature. Like it has totally 4 pages will come, including the questionnaire and the PSC chart. So now here comes the question, if this consent form is getting signed by us, so this total 4 pages with complete patient understanding and all. So we are definitely, if you read the content there given also, you will agree that you will not be any legal soup unless there is a gross mistake from our side. So how much time we can spend in the pre-anesthetic checkup? That's again a question mark. So are we spending now enough time for PSC and again getting this questionnaire answered and getting the consent, detailed consent, making them understand and getting them signed? How much time we can spend in the pre-anesthesia time? And also, will there other practical problems, like if it is so detailed explaining all the pros and cons and all, sometimes the surgeon or the management can pressurize that you're telling too many things, they will fear and run away from the hospital and all. So your light on this one, a proper pre-anesthetic checkup and consent, explaining them all the pros and cons. So what do you feel?
We should definitely think, explain all the pros and cons. I feel we should definitely think, because if anything happens in the perioperative period, the whole brunt will be on the anesthesiologist. Everybody goes off. So we should, either the surgeon agrees or the management agrees, we have to adhere to the safe practice of anesthesia, and we have to explain the patient all the pros and cons of the procedure, all the pros and cons of the type of anesthesia we are giving, and we need to explain how we are going to, what is our second plan also. I mean, what is the backup plan for if anything goes wrong? Because most of the corporates and most of the hospitals today, we are doing ASA grade 3 and grade 4 cases only. ASA 1 and 2 are done by are very little. What we are doing, in a particular late care, ASA 1 and 2 are very little, coming for minimal procedures. But so we have to explain the patient and the attendants if at all patient is not there, sometimes explaining to the patient will make them panic. So that's the thing is there, but we can explain the attendants about what is what, and we can take up the case after proper consent only.
Okay, nice. Anyone else to talk? Chaitanya, Venkatekrishna, Kiran, Shyam sir, Sharda. Regarding the pre-anesthetic checkup and consents.
Srikanth,
Sir.
sorry, even though I'm not practicing much, but I'm also a medical director now, so I'm seeing little issues also. Some issues come to me.
Yes,
Now
sir.
here, what happens is the surgeon patient coming for a spine surgery, some major surgeries, and coming with having a PTCA, post PTCA, CAPG, and all these things. The surgeon says that nothing will happen. As simple ఏమున్నదండి నట్టు బోర్డులు వేసినట్టు వేసేస్తాం చేస్తాం సర్జన్ చేసి ఏం లేదండి పోతే ఒక 7-8 రక్తం బాటిల్స్ పోతాయండి అది ఇచ్చేస్తామండి నో ప్రాబ్లం కొంచెం బ్లడ్ ఎక్కువ పోతుంది దిస్ వర్షన్ దేటే our surgeon. Now this fellow goes to anesthesiologist PSC. PSC, no, this pelvic repair and huge blood loss and already having a post PTCA patient, EF is 40%. It's a very high risk. Sometimes patient can have a death in the table, death on the table, post-op ventilation, post-op shock, acute MI. All these things you tell. Okay. Now that fellow goes to surgeon and says, "Sir, భయపట్టిస్తున్నాడు అది చేయించుకోమండి అని." These are the things really I'm witnessing. So what I'm doing is I'm in front of any such type of high risk patient, I ask anesthetist, boss, sit with surgeon and explain the risk. Because this is a thing happening, you both discuss, and as a family meeting, you update the patient. Srikanth.
Yes, sir.
Sir, here I would like to interject, sir. As a medical director, what is in the best interest of the hospital? Whether we should be explaining the risk or get the revenue.
Sir, first, నాకు అర్థం కాలేదు. Get the revenue or
explain the risk. It means
sir, best
even
as a medical director,
only
sir,
100 cases, only 100 cases, 10 people are going to land in trouble. That's the maximum. So let's operate the 90, take the revenue and give to this 10 people. Is it the way we should be operating?
Sir, as a medical director, I have two objectives, sir. One is best outcomes for the patient. Second is the revenue. So these are my two objectives. So I need to work between these two frameworks.
Two object lo first object enti?
Sir, quality, sir. Quality.
You have two objects lo first object enti?
First is outcome, sir.
And here
nee object kaadu, hospital object enti?
Sir, hospital objective is revenue, sir. Revenue, brand building. And again, it comes into the revenue, sir.
See, brand building always comes at a cost of revenue, sir.
So
some sacrifices have to be made.
Sir, top management always sees about the revenue. Adi most are telvandem kaadu. Kaapothe as a medical director,
let us discuss more clinically. But what I'm telling is the points నేను ఎందుకు చెప్తున్నానంటే మనకు this has to be for anesthesiologist. మెడికో లీగల్ గా మనం సేఫ్ గా ఉండాలంటే ఏం ప్రాక్టీస్ చేయాలి అది మోర్ ఇంపార్టెంట్.
Yes, sir. Yes.
As a fraternity of other anesthesiologists, what are things we should do to be safe from our side to be medico legal? Tomorrow, we know so many cases we have faced and we know so many problems. Still, how to avoid? ఇప్పుడు నువ్వు చెప్పినట్టుగా ఇప్పుడు మోస్ట్ ఆఫ్ ద ప్లేసెస్ సెకండ్ ఇయర్ డిఎన్బియా, ఫైనల్ ఇయర్ డిఎన్బియా, టెక్నికల్ అసిస్టెంట్ శ్రీకాంత్ ఫ్రెండ్ లాగా ఎక్కడ ఉంటారు ఏంటి అదని పక్కన పెట్టేసి what is important, what is safe. So that is very, very crucial. సో కాబట్టి దాని గురించి ఆలోచించాలి. ఎందుకంటే ఇప్పుడు మనకి సర్జన్ ఒక ఆయన నేను మాట్లాడితే పెద్ద డోంట్ టేక్ ఎనీ నేమ్స్ ఇన్ టాక్స్, బట్ నార్మల్ గా బాస్ నేను కన్సెంట్ తీసుకోకుండా హై రిస్క్ చెప్తే నా దగ్గర ఖర్చు పెట్టించుకోడు, మీరైనా మీరు చెప్పేసుకోండి, మీరేం చేసుకుంటే చేసుకోండి, వాడు చేసుకుంటానప్పుడు చేస్తా అంటాడు. కొంతమంది పేషెంట్స్ పోతారని బాధపడతారు, వాళ్ళకి నిజంగానే తెలియదు. మోస్ట్ ఆఫ్ ద టైమ్స్ వెన్ యూ డూ టుగెదర్ ఓన్లీ ఇట్ హ్యాపెన్స్. లైక్ సర్జన్ అనసిస్ట్ పక్కన కూర్చుంటే మాటలు వేరుగా ఉంటాయి, ఐసీలో ప్రైమరీ కన్సల్టెంట్ పక్కన మనం కూర్చుంటే వాళ్ళ మాటలు వేరుగా ఉంటాయి, వాళ్ళు ఒక్కళ్ళే ఉన్నప్పుడు వాళ్ళ మాటలు వేరుగా ఉంటాయి. సో మోస్ట్ ఆఫ్ ఇవన్నీ కూడాను అవి కూడా సర్జరీ చేస్తారు బిఫోర్ ద డెత్. ఏఎస్ఏ గ్రేడ్ 5 వరకు కూడా వెళ్తాం. సో దెర్ ఇస్ ఏ అపాచీ స్కోర్ ఐసీలో ఉన్నట్టుగానే ఏఎస్ఏ గ్రేడింగ్ స్కోరింగ్ ఉంది, దానికి అవుట్కమ్ ఉంది, దాని రిస్క్ ఫ్యాక్టర్స్ ఉంది. అవి మనం ఎవిడెన్స్ చేస్తేనే ఎవిడెన్స్ అనేది బాగుంటుంది. అంటే ఎవిడెన్స్ ఈజ్ ఆల్మోస్ట్ ఇంపార్టెంట్.
That is the only thing that protects the hospital in the long run also, sir. Because one case is sufficient, because awards are not that high now, but they are going to increase in the future.
అగ్రీ సార్. అందుకనే హై రిస్క్ పేషెంట్స్ ఉంటే కనుక బోత్ సర్జన్ అండ్ అనస్థిస్ట్ ఇద్దరు కలిసి కౌన్సిలింగ్ చేయమని చెప్తున్నారు. అది కూడా వీడియో రికార్డెడ్.
Sir, it is all about see what I think or you think. It is about what the evidence says. That is more important. See, we have to just put it on paper what the evidence is saying. That is what I am trying to say here. That keeps everybody safe, including the surgeon, even though he is reluctant to admit it. He might feel it differently, but it is for his good. The medicine is bitter, but it has to be swallowed. That's what I am trying to say.
Right.
Can I say one word?
Sir.
Shrikant?
Sir.
Okay. So, see, anytime you cannot store the video recordings of all the patients. The only evidence is the document. That is purely evident. Because video recordings, online, these things, unless it goes to the cloud system or this one, it is not going to stay for long. When he is going to put in the code, we don't know. So, always have a proper chart, proper writing, and proper signatures are going to take a long way and better way. Thanks. And I will not talk.
And thought about surgery specific consent forms, how many of us are using them? Because very recently, just 2 years back, there is a case for cholecystectomy, and the court blatantly refused the consent form taken by the hospital and anesthesiologist, because it is a common consent form and it doesn't highlight the risks especially associated with a laparoscopic cholecystectomy, and find the anesthesiologist, surgeon, and the hospital. This is like somewhere around 3 years back, I think. How many of us are taking a surgery specific consent form?
Can I speak?
Yeah,
this is the major problem in most of the hospitals. 99.9% of the hospitals will take a blanket consent. So in that blanket consent, not everything will be covered. At the same time, only probably if in a cardiac center like CARE, there is another consent form specific for cardiac procedures only. That doesn't involve any other procedures or any other specialty. So there is a blanket consent, and there is a specialized 1 or 2 big department consents. Those are only will be there in big hospitals also, like corporate hospitals also. So the major problem that is going to be in future is this. So we cannot take a blanket consent for every procedure. We cannot, because every procedure is special in its own right, and every procedure needs to be, the risk factors are more, and the procedure done by the surgeon and the surgical procedures are very different. We cannot take a blanket consent. That's what I feel. But the thing is, how far we are there from reaching there, I don't know. That needs to be taken by the hospitals and the policymakers.
okay. So
సార్ ఇది కన్సెంట్ ఫార్మ్స్ లో వాట్ దే విల్ బి, ఇప్పుడు కొలిసిస్టెక్టమీ అని రాస్తాం కదా, అది జనరల్ వర్డింగ్ ఉన్న తర్వాత వాట్ ఆర్ ద మేజర్ కాంప్లికేషన్స్, వాట్ ఆర్ ద పోస్ట్ ఆపరేటివ్, ఇంట్రా ఆపరేటివ్, పోస్ట్ ఆపరేటివ్ కాంప్లికేషన్స్ అని అది ఫిల్ ఇన్ ద బ్లాంక్స్ లాగా డాష్లు ఉంటాయి. Basically, this is the JCA model of the consent forms present with Apollo. I see the similar type of consent forms in every hospital in Hyderabad. So, అది almost JCI mandatory గా Apollo తీసుకుంది. So, modify చేసింది. I see every hospital is having similar consent forms. ఆపరేటివ్ నోట్స్ బుక్లెట్ ఉంటుంది. ఆ బుక్లెట్ లో PSC నుంచి intraoperative, consent forms, post-operative అన్నీ ఉంటాయి సార్.
Sir, if you have no objection, one share that PDF. If they have no objection, you have a soft copy.
Definitely, sure.
And
if,
sir, madam.
If it's a general consent form, what NABH says is, after you put the surgery name there and you have to mention specific complications related to that surgery. That also you need to write there if it's not separate consent forms for each procedure. That's what they said. When they checked the consent forms, they said, no, you can't just put the surgical name, the surgical procedure name. You have to mention specific like complications which are not there in the printed matter. That's what they said. Then only it is full consent form, proper consent form.
NABH booklet lo that much space is there, madam. I didn't find it.
ఎక్కువ లైన్స్ ఫిల్లింగ్ ద బ్లాంక్స్ లాగా ఎక్కువ లేవు కానీ దేర్ ఈస్ ఎ లైన్. ఐ థింక్ దేర్ ఈస్ ఎ లైన్, బట్ ఇఫ్ ఇట్ ఈస్ నాట్ దేర్ ఆల్సో అండర్ ద సర్జికల్ ప్రొసీజర్ స్పేస్ ఉంటుంది కదా, అక్కడ పెద్ద స్పేసే ఉంటది. ఆ ప్రొసీజర్ అండర్ లో కాంప్లికేషన్స్ లైక్ అని సో అండ్ సో రాసి ఎక్స్ప్లెయిన్ టు ద పేషెంట్ అండ్ అటెండర్స్ అలాగేదో రాయాలి సర్జన్.
Okay. So if you can remember, few months back, actually we started this after knowing about the lawsuit. We started a separate a single A4 sheet paper and shared that in Morton Group 2. Hope few of you remember that one. So that's a very simple one, and me and Onkar have designed that one, and so it has got name of the patient, IP number, and surgery. In that it will be age and sex, regular details, and the surgery proposed, anesthesia proposed, and anticipated surgical complications we have kept to 1, 2 like that, and anticipated anesthesia complications again at 2 numbers are there, 1, 2, and below that surgeon signature, anesthetist signature, and below that patient signature and attendant signature. And in case of minor and all, we have added these things in a simple A4 sheet and taking on since it's almost like 1 year, I think, madam. So for each surgery, we are taking that one, and we have asked surgeons also to fill up for the local anesthesia cases also. They're filling up anticipated surgical complications and all. So though at least 50% of the routine stuff they're doing, like bleeding, infection, and writing like that. But most of the time it's working out for us. Initially, it been very difficult to convince them to sign another paper and write few lines in it. But like we persisted with that. It took like 2 to 3 months to get them documented that one. But we are following in ABC that particular one. Maybe Wonkar didn't join today. Venkatekrishna may have seen a few cases and those consent forms. So I will again share a copy of that in the model. Hopefully it helps you, even though it's not so complete and all.
Good morning, Srika. Good morning, Srika.
Madam.
Can I tell?
Yes, madam.
Okay. So in our hospital, we are following 3 consent forms. One is
Okay.
informed consent for surgery and procedure. So in this form is surgeon will sign, and here reason of selected treatment modality is expecting, so that is benefit or not. Like improvement of symptoms, better outcome to save life, improve quality of life, other things you can add. So in this form, the surgeon will sign and patient family. And the second one is our consent from anesthesia. So different types of anesthesia: general, epidural, spinal, with sedation, without sedation, monitor care, regional, intravenous, like this is given. And a change of anesthesia. We are proposed one anesthesia. So any event occur, we immediately are changing the gender, regional to gender. That also we have to write the form. And here also patient and anesthetist will sign. And third one is a high risk consent form. Here surgeon and anesthetist will sign. And here already pre-existing risk factors are there or not. So you can write 1, 2, 3, 4. Next, and what are the complications for a high risk surgery like bleeding, long ICU, dysarthmias, MI, bleeding, neurological problems, respiratory distress, renal, hepatic, multi-organ failure, age-related, any fatality, like 1, 2, 3, or 4, like 10 or 15 points are there. So we can tick that complications are will occur. So in this form, patient or any surrogate and a surgeon and anesthetist. So 3 forms are we are filling.
For cardiac, madam, or routine surgeries also?
Routine.
Routine.
And
Very
if normal case, it's okay. If a high risk case, extra third paper, high risk consent form.
there is consent to
So,
the right.
yeah, 3 we are following. Thank you.
Okay. Then we'll move to presence of an anesthesia machine or workstation monitoring equipment. The OR should have a functioning anesthesia machine. Madam.
We can talk a point regarding
Madam.
consent. On the PAC form, like there is a immediate pre-op review is there. We
Yes,
have
ma'am.
to, we must complete that and sign. Then
Yes, ma'am.
only like it's accepted PAC form. Because when there are so many people in the group, somebody may do the PAC, but whoever is doing, they do the immediate pre-op review. So that they have to check and sign. And also many times we say like some of the investigations to be done and to be reviewed. So that review part also compulsory need to be filled and signed. Otherwise, the PAC is not completed. That's what NABH inspection says. Many times in a rush, we may forget to fill that or sign that, but that need to be signed as well. And if any anesthetist written like this drug has to be stopped for 5 days or 7 days, and when it's written there, if we have done before that, if there's any complication occurred, if that form goes to the court, actually anesthetist will be at fault because we only said we have to stop this before we take the patient. But why did we take? So there should be a justification form or in the notes, we have to document if we have taken earlier. So that also to be there. And if there's any problem occurs in OTs, the in charge of that OT is responsible. We have like students, DNB students, PGs, juniors, everybody, but the total responsibility will go to the in charge of that OT. So as Shekhar said, we have mostly grade 3, 4, say grade 3 and 4 patients mostly in corporate. So we have to be very careful like that somebody is at least around in the complex before we take sick case. Thank you.
Thank you. So regarding the equipment, we should have a functioning anesthesia machine or workstation, defibrillator, monitoring equipment in working condition, essential medicine, and airway equipment. So the anesthesiologist should ensure availability of a checklist in OR. Thanks to NABH, we have a documented checklist for each case and perform it before giving anesthesia to patient. So adequate facility to manage emergency and to transfer patient if required. So just after noting a few functioning of city branch, we'll just move to that equipment and all what they have given. So functioning of city branches, time has come for us to stand united and progress to take our specialty and its honor to new heights. So unitedly, we can bring a major shift in perioperative care. Today, the only way to create a healthy working atmosphere in your city is to unite against all adversities faced by us. So to achieve this, ISA recommends the following. Regular monthly meetings is a must. Even over a cup of tea is okay. Clinical topics, difficulties in practice, setups, black sheep, etc. should be discussed. So public awareness is awfully lacking. They have quite a few suggestions for that, for creating public awareness. Starting your own pre-anesthesia clinic, which is being stressed on in many conferences and by seniors. So in each hospital, or at least visiting the patient preoperatively and in postoperative period. Anesthesia specific consent forms with a preoperative questionnaire to be handed out to patient once he has been posted for surgery in local language. So designing and pasting posters imparting knowledge about anesthesia with pictorial demonstration of modes and techniques of anesthesia. Designing anesthesia related interactive websites with thorough knowledge about anesthesia and experts replying to queries from the public. Making a film about anesthesia techniques. Organize conferences on anesthesia, analgesia and pain management. And press releases for all events should be a routine so that local media always publish your events. Invite state or national dignitaries to your city. Teach CPR disaster management to all general public, media persons, paramedical staff, and policemen. World Anesthesia Day should always be celebrated in a great pomp and ceremony on a public platform. Make a deal with local radio and TV stations. Wear color-coded T-shirts with simulating captions such as "We care when you are not aware." So the color of these T-shirts can be of our national ISA flag, and wear them on a regular basis, be it professional or social events. So what better way to promote ourselves? Anesthesia card post-op can be effective, especially if patients have some problem during anesthesia. The social communities like Rotary Lions Club can be used as interactive platforms. So we should have a frequent non-academic events, meetings with family, ladies, special picnic, treks should be encouraged. Attend conferences and CMEs as a group so you spend more time with each other. Organize conferences, workshops, not only for anesthesia but also on pain, labor anesthesia, bringing all specialists to a common platform. Celebrate festivals of all communities together. Frequent meetings and interactions help in a cohesive, stress-free atmosphere. New and junior colleagues should be warmly welcomed and seniors duly respected. Also, opinions sought from seniors should be diligently managed. A grievance cell should be set up in each city as also a rescue team to help members in times of distress in OT or ICU. So if possible, having an office is very beneficial. They have an office in Nashik for this purpose. Set up minimum monitoring standards, uniform charge structure in each city, which is again a big challenge, creating a uniform charge structure. Use media to your advantage. Actively involve your members for disaster management events such as Kumbh Mela or large public gatherings. So increase your self-esteem by thinking of following. We should be non-exploitable and full of self-esteem. So ISA recommends that we must unite against diversity, love of our profession, make our life the best by changing the attitude. So these are the few suggestions for the city branches made by the ISA to avoid the disasters and to promote more harmony among people. So we have no discussion on this one. We can move ahead with the ethical conduct of anesthesia. So some we are already practicing, so World Anesthesia Day celebrations and all, and also not about ISA in general, but as a team, Morton team, we are Mohan sir is always just to conduct the social gatherings and non-academic meetings also, in additional to academic meetings, and also as the workshops and organizing here in the city has been always telling the same. We should organize a CMA workshop here, and these are all the how a city branch should ideally function. Any views on this one, or we'll move ahead? Okay. So coming to ethical conduct of anesthesiologists. So the ISA recommends following its to member perform a pre-anesthetic checkup of the patient.
ఎవరు మాట్లాడలేదా దాని గురించి?
Sir, ఎవరు city branch గురించి మాట్లాడలేదు సార్.
అలా కాదు ఎవరు ఇప్పుడు యువర్ ట్రెజరర్ ఆఫ్ దిస్ సిటీ బ్రాంచ్ కదా.
Yes, sir.
సో అలాంటప్పుడు ఫర్ ఎవ్రీథింగ్ for conducting anything, the finance is most important.
Yes, sir.
What you said, so many things. At the same time, whenever you told something regarding conduct and time, there are only two things required by everybody. One is a time and second is a money. So who's going to spend that much time for this? Because whether you're keeping 24/7 in the OT, or you have a less doctors and more work, and you have a less remuneration and more cases, and you're telling that to be a good anesthesiologist in this one in the city, you made so many things. Even if you do, everybody's crying that we are wasting our Saturdays, Sundays. We are doing so. Then when you have to do that? So what time you have to do that? You cannot do in the clinical work. You have to do in out of the time, and you have to do in your family time. You have to do your professional time. So all the list what you are given, going in team awareness, publications, newspapers, or radios, or Rotary clubs, all these things you told. You gave me the list of almost 9 to 10 things you are given.
Yes, sir.
So for that, do the society, a society of the Vaishakapatnam or any society, as in Nasik, they have a separate office, you told. So for medical legal cases are helping. If the new anesthesiologists come to the city, can anybody provide the job to him? Forget about all these things. Can anybody can provide the job to him? Because we want to develop, there's one way you want to develop anesthesiologists in the society, you want to make the awareness in the public. What about the fraternity? What we are going to do with the fraternity? You want to make more and more trained people. What you are going to do with the training people? Because I want myself, I want to increase my salary. I want to work. How do I give the other person job? Or not me, hospital. It's not our problem, no? Hospital has to take care, or society has to take care. So when you are handling with the ISA, all the guidelines, is it any minimum standard of after this one? Because it always depends on like a market. In the city, it's less. If you go to the major city of Bangalore, you'll get only 60 or 70,000 once you complete MD. If you go to small city, 1 lakh. I mean, so many things are going to be there, no? So we cannot ask the society to make a development of the rules. These things, only thing my suggestion is that make a percentage of budget for promotion activity, either World Anesthesia Day, or because it's very tough. You fix a budget of percentage, not the percentage, because certain society is having only 1 lakh. Then 10%. Society is having 10 lakhs. Then again, percentage will not change. Only the money will change. So that is the one suggestion I want to give you as a treasurer. Thank you.
Thank you. So, okay, thank you, sir. We'll go ahead with the ethical conduct. So, perform a pre-anesthetic checkup of the patient before taking the patient for surgery. So, even though it sounds so routine for us doing so many cases and all, this is equal so many times even in hospitals too. We are sometimes maybe we are outside or nobody is there in the hospital, or maybe the call for an early morning case. Call for PAC comes late at night. We are missing this one. So it's very important to visit the patient before the surgery and perform a proper pre-anesthetic checkup so that there are no surprises when you go to the case. So ask all your surgeons to send all patients of elective surgery for PSC. So again, you should have a good rapport with the surgeons and all, so that you can ask them not to bring them along. There are some of our ENT surgeons who bring the patient along with them in their car also, so that they do not lose the patient. Same time the surgeon and the patient comes. These things, sort of things used to happen. Fortunately, nowadays it's not happening, but I have seen all these sort of things. So they use the ISA recommend questionnaire and PSC format for documentation of PSC. I will share that PDF with all of you. So performing PSC helps in establishing a rapport with the patients and their family. Do not forget to communication of the documentation and documentation of communication. Both are very important as the key to success in medical legal cases. So communication of the documentation and documentation of communication. So both aspects are very important for success in medical legal cases. So always optimize the patient before taking up for surgery, get proper investigations and references done for the type of surgery and patient and document it. So consent, always obtain a separate consent form for anesthesia from patients after explaining him the technique, alternatives and answering his queries. So ISA recommends the use of consent format as given by them. So these are the 3 points mainly they stressed upon in the ethical conduct of anesthesiologist, and the consent and anesthesia record and all. I will share the a PDF with you so that you can have a look on the questionnaire and the consent and all. So we'll quickly move to the list of minimum mandatory equipment in OR suggested by ASA. Continuous supply of oxygen cylinders, gas pipeline, anesthesia machine, workstation with 2 oxygen cylinder and a nitrous oxide cylinder, 1 emergency oxygen cylinder mounted on anesthesia machine with a spanner, anesthesia machine with hypoxic guard safety system, working suction machine with all connectors, suction tubings and suction catheters of appropriate sizes, multi-parameter monitors including pulse oximeter, ECG, NIBP and ETCO2. ETCO2 they made mandatory for all laparoscopic surgeries and use of closed circuit, desirable in all cases of general anesthesia. So it's mandatory for all laparoscopic surgeries and wherever closed circuit is used, and desirable in all cases of general anesthesia. Thermoprobe for temperature monitoring. Defibrillator is a minimum mandatory equipment in OR. Adequate number of protective lead aprons, protective glasses with laser surgery, ambu bag with all size of mask, working laryngoscope with all size of blades, Miller blades for pediatric patient, oral and nasal airway all sizes, intubating stylet all sizes, masses forceps, endotracheal tubes all sizes, peripheral venous cannula starting from 14, 16, 18, 20, 22, 24, 26. Spinal needles from 23 to 27, epidural set size 16, 116 and 118. Three-way connectors and extension tubing, IV sets, microtrip sets, blood transfusion set, scissors, ampule cutter, torch, thermometer, syringe pump, infusion pumps, nebulization machine also they have included in the minimum mandatory equipment in the OR. So in difficult airway cases, wherever you mention in the PSC form that it's going to be a difficult airway. So mandatory or intubating buoy, LMA, McCoy blade, cricothyroidotomy set, 14 and 16 gauge needle. Desirable is in intubating LMA, video laryngoscope and fiber optic intubating scope. So tilting OT table should be present. Radiant warmer or blanket is an optional. Heating mattress, fluid warmer is an optional. So post-operative recovery room with oxygen supply and monitors. So again, the drugs and all they have given, but these are the minimum mandatory equipment. So what are among this list given by our body? What are the things we generally miss? I mean, like nebulization machine is one thing we are not routinely keeping in the OT or maybe in our hospital, wherever you are keeping, and also some things like intubating stylet and oral and nasal airway. Oral airway we have all sizes generally in most of the OT7 and peripheries and all, but nasal airway are we keeping routinely in all operation theaters?
Can you type that and put it in the list?
Yes, sir. I will send this complete guidelines PDF, sir. But few and most of these ambu bags for working anesthesia machine, defibrillator, and everything will be having. So I'm just asking among these few like nasal airways, uncommon things I'm asking. So just nebulization machine and all. Minimum and the most important one is like that ETCO2 always we have this question, what are the guidelines by SA? So it is mandatory for all laparoscopic surgeries and use of closed circuit, desirable in all cases of general anesthesia. So that's it, sir. This forms and all I will share this one. So they have this regarding the pay structure, they have this it's definitely a very tough job to get a uniform fee structure, but some I think they have taken this from western part, relative value guide RVG, and they have designed it for India. So they will calculate some base units and all, and time units and modifying units, like if it is a high risk surgery and all. Like that, they have identified base units for based on the surgical procedures and all. They have noted like 4 units for minor procedure, DNC, biopsy, and all 5 units for diagnostic radiology, RCP. Like that, it goes on. And to add it, if it is an age less than 1 year or more than 70 years, they will add obesity. They will add if you are putting an arterial line, central line, like that, high risk cases and all. So based on that, they will multiply the units with the money, and they have taken this as 300 rupees in Indian currency for each unit and calculated that one. So it's again a tough job to get a uniform fee structure for the entire city to be followed in all the hospitals. So these are the ISA guidelines, sir. I will share the PDF and all. So just I want to stress upon the minimum mandatory equipment and also the mainly the consent forms and all surgery specific consent forms to be applied for all hospitals. It's sort of easier thing only. We can face a few months of resistance initially for getting them signed in separate paper. So many times our anesthesia colleagues itself may miss the documentation and all. But this simple surgical specific consent forms and being present before and after surgery, ensuring the patient, and few of the city branch things we are already doing, and we can plan some more, like even we can start at a hospital level to increase the anesthesia awareness among our colleagues, junior staff, floor staff and all. That's it from the guidelines part. Thank you. Any further inputs and all are appreciated.
I want to hear a few words from students also.
Yes, ma'am.
చైతన్య కూడా మాట్లాడలేదు.
Hello, sir. Good morning, sir. Actually, OT lo unnaను, sir. All high risk cases, so I could not answer this. Shrikant, sir, actually a very good topic, sir. As you said, yes, pre-anesthetic checkup is very, very much important, and optimizing the patient, even ante all elective cases ఖచ్చితంగా పిఎస్సి చేయాలి అన్నారు. ఈవెన్ ఎమర్జెన్సీ కేసెస్ అయినా కానీ getting everything ready, at least blood products అవసరం ఉండొచ్చు. Whatever is ready, I mean whatever needs to be kept ready, that even that has to be done. So either it is an elective or emergency case, pre-anesthetic checkup and is mandatory. And మీరు రాణి మేడం చెప్పారు, because correct గా before the surgery, women anesthetist who done the PAC might not be the one who is doing who is giving anesthesia on the same day. So even correct ga also pre-anesthetic evaluation just before taking the patient into the OT is also mandatory. And ivala at present there are 2 OTs with two high risk cases are going on, and I totally feel this is very relevant, because both the cases we have taken written high risk consent from the patient attenders, and along with the video counseling. So video counseling might not be, thank you sir, might not be just sufficient. So written high risk consent is also mandatory, as rightly said by Mohan sir. So yes,
Yeah, thank you, Chaitanya. Anyone else? Kiran, Shyam sir, closing statements. Krishna.
Shrikant,
Madam.
జక్కిన శ్రీనివాస్ చెప్పారు కదా, ఒక ఎగ్జాంపుల్స్ సర్జన్ సింపుల్ గా చెప్పేస్తారు, బట్ వెన్ ఇట్ కమ్స్ టు అనెస్థెటిస్ట్ ఇవి అవి అన్ని కాంప్లికేషన్స్ చెప్తే దే గెట్ వరీడ్ అండ్ దే డోంట్ వాంట్ టు గెట్ ఇట్ డన్ ద ప్రొసీజర్. అలాంటి సినారియోస్ ఉంటాయి, బట్ It depends on how you explain to them. PAC time low, like you have to stress the point that this patient needs to be done, but accepting the risk. But if you don't do, the risk will be even more. So you have to explain to them. If they don't get it, they'll be in more problem. So they have to understand, and at the same time, explain like a post-op, they may need ICU or ventilation, whatever required, and if complications occur, people are around. All these things, if you explain like accepting the risk, they'll give consent. But if you just say all those complications on table death and just leave it to them, they get worried, right? So say if you don't do, definitely death risk. But if you do, there is a chance he may make it. So those things need to be explained. Sometimes in such a really complicated cases, a senior, and as Chaitanya said, video counseling, high risk consent, all these need to be taken, and explaining and little reassuring also is necessary.
Thank you. Okay. Anything else to be added? Students అందరూ బాగా సైలెంట్ గా ఉన్నారు మేడం. Your current time practicing anesthesiologist. Okay, right. Thank you then. So I have shared that ISA PPF guidelines for practicing anesthesiologist. So if feasible, you can add that questionnaire and also the consent form if it is okay with your management and anesthesiologist. You can add that ISA guidelines what they have given there, the questionnaire and the consent form. If you have time to do all those things, it would be definitely better. But the easier one is following this regular NABH consent form with a, like Anuradha madam said, and like what we are following at ABC, that each surgery there is a separate specific consent form where just labeled 2 surgical and 2 anesthesia, and you can add on in that space is good enough on an A4 sheet. So with both surgeon and anesthetist signature, so that we can actually happily pull him also into the soup. And the separate high risk consent, all the hospitals will be having for high risk surgeries, high risk consent form. And also keep a check on the minimum mandatory equipment needed in the hospital, in the operating room, and most importantly, ensure they are in working conditions. Like suddenly you can get an unanticipated difficult airway, then you can't keep on searching your bags for an LME or a stylets and all. So keep everything ready, ensure everything is placed. So even we all know in our years of practice that even a normal case can go wrong anytime. Unanticipated difficult areas, we all have seen difficult spinals and all. So be ready, and the team activities are already going reasonably good in our city with able leaders like Mohan sir, madam, and all. And we hope to improve even more. We are following most of things. We are growing as a group. The registration sometimes done by the Morton team. Sometimes sir is waiving of some amount and all. We are going to conferences and groups like that. It's a good thing. Hopefully, we will continue the same way and increase even more. Some non-academic meets and all. So thank you and all. Thank you all for very valuable inputs and regarding the guidelines, ISA guidelines. So we'll meet next week with the Gajuwaka team class. Mostly Ganapati, I think, will be the speaker. I will let you know. Thank you so much. Thank you, Mohan sir, Rani madam, Chaitanya, Shyam sir, Shekhar. We'll wind up.